Hello everyone. Today we are going to discuss in detail about the drug known as quetiapine. It's a second generation antipsychotic and we'll be discussing this drug in detail. My name is Dr. Shubham Chauhan. I have completed my MBBS from AIMS Bhopal and MD from Lady Harding Medical College and I am here to teach you in detail about quetiapine. In quetiapine, we'll be discussing in detail about its classification, the pharmacokinetics, the pharmacodynamics, the famous three-beer hypothesis of quetiapine, its drug-to-drug interaction, special population, dosing strategy, its mechanism of action, and a comparison with the other antipsychotics. And at the end, we will be summarizing the whole of quetiapine. So coming to the classification section, coming to the classification of quetiapine. So what is actually quetiapine? Quetiapine is actually a second generation antipsychotics. Okay, it belongs to the group dibenzothiazepine group. Okay, it's a second generation antipsychotic belonging to dibenzothiazepine group. Structurally, it relates to two of our antipsychotic, the pines. What are the other two pines? The clozapine and olanzapine. What are the other two drugs which it structurally resemble to? That is clozapine and olanzapine. If we see by the NBN classification, which we have discussing earlier also, the NBN classification means neuroscience based nomenclature. It neuroscience based nomenclature. It based on this, its pharmacological domain mainly belong to three categories. Which three categories? One is the dopamine, second one is serotonin, and the third one is norepinephrine. Based on the neuroscience-based nomenclature, it acts mainly has three pharmacological domain. One is dopamine, the second is serotonin, and the third one is norepinephrine. So coming to its mode of action. Coming to its mode of action. So it has mainly two mode of action. Two mode of action. The first mode of action is it's an antagonist. It's an antagonist. On which receptors? Mainly D2 receptor and 5-HT2 receptor. It's an antagonist at D2 receptor and 5-HT2 receptors. And the second action is it's a reuptake inhibitor. What it is? It's a reuptake inhibitor at norepinephrine transport. It's a reuptake inhibitor at norepinephrine transporter. So from this we can really clearly see that since it is a reuptake inhibitor at norepinephrine transporter, so it will be increasing the level of norepinephrine. So it has also a role in depression, mainly bipolar depression. So if we see clinically, quetiapine is not only used for psychosis, but it's also used for mood disorder, mainly in bipolar depression, as well as in major depressive disorder augmentation. And also, it is because of its properties, it has an off-label use in anxiety and insomnia. So it is distinct from the other second generation antipsychotic in two ways. So we'll be seeing how it is distinct from other SGAs. That is primarily because of two reasons. First, what is the first reason? It has relatively low affinity for D2 receptor. What it has? It has relatively low affinity for D2 receptor. The second is fast dissociation. Remember this, this is an important concept here. Fast dissociation from D2 receptor. Fast dissociation from D2 receptor. So what we terminology we use for this, that is loose binding. What terminology we use? Loose binding. So now these are the two reasons. Do remember, these are the two reasons. One is the low affinity for D2 receptor and the fast dissociation from the D2 receptor. It's responsible for its first lower risk of EPS and second lower risk of hyperprolactinemia. Why hyperprolactinemia? Because D2 antagonist causes increase in the prolactin. So since the D2 binding is low here, and there will be a fast dissociation from the D2 receptor, so the D2 receptor will be occupied for a less time period. So there will be less chances of hyperprolactinemia. Okay. So because of these properties, it has two major advantage over the other SGS. Okay. Now coming to a detailed mechanism of action. Coming to the detailed mechanism of action. Detailed mechanism of action. So if we want to, since it has action on multiple transmitters, so we can say quetiapine is a multi-transmitter antagonist. Are we correct? Multi-transmitter antagonist. Why? It's acting both on D2 as well as 5-HT2 receptors. So if we come to see the clinical effects of quetiapine, the clinical effect of quetiapine is mainly mediated by two compounds. Which two compound I am talking about? Which two compound? First compound is quetiapine. Understood? So the clinical effect first compound is quetiapine. Now quetiapine will be going into the liver. It will be getting metabolized into what will be it will be getting metabolized? Nor-quetiapine. Nor-quetiapine. Okay, understood my friends? Nor-quetiapine. So what is the role of nor-quetiapine? Norquetiapine has a major role in antidepressant. Major role in antidepressants. So if you look, both quetiapine and norquetiapine together will be responsible for treating psychosis as well as depression. Understood, my friends? Okay. Now coming in detail on the action on the D2 receptors. Coming in detail on the action on the D2 receptors. So first, it acts as an antagonist on the D2 receptors. By acting as an antagonist on the D2 receptor, it will be going into the mesolimbic pathway, where it will be antagonizing the increased dopamine in the mesolimbic pathway, and hence will be acting as an antipsychotic. Understood, my friends? So at the same time, we see that D2 receptors, D2 receptors have low affinity and fast dissociation. Quetiapine has low affinity and fast dissociation from the D2 receptors, which will be actually responsible for low EPS. So to see this, if we see in terms of numericals, that D2 occupancy due to occupancy of quetiapine fall to about fall to about 0 to 20%. 0 to 20%. Mind my friends, it falls to about 0 to 20% in 12 to 24 hours after the last dose. So you can clearly see how fast it is getting dissociated from the D2 receptors. Okay. So what it means clinically. So everything will be understanding concept. Right? What does this mean clinically? The time period is sufficient to produce an antipsychotic effect. The occupancy time period is sufficient to cause an antipsychotic effect. And at the same time, since the occupancy decreases in next 12 to 24 hours, it decreases the risk of EPS as well as hyperprolactinemia. Why? Because the D2 receptors are not continuously and tightly blocked. Now coming to the serotonin receptors. We've discussed about the dopamine receptors. Now we will be discussing about the serotonin receptors in detail. It had low affinity for D2 receptor, but on the contrary, it has high affinity. High affinity for what? For 5-HT2A receptors. 5-HT2A receptors. And it is greater than that of D2 receptor. Okay. Because of this greater affinity, because of this greater affinity, it gets its name of atypical antipsychotic. Okay. And again, low APS. So all are these reasons of the low APS. At the same time, quetiapine blocks two more serotonin receptors. What are they? Two more serotonin receptors. What are they? 5-HT2C receptor, 5-HT2C receptor, and the second one is 5-HT7 receptor. Understood, my friends? So earlier in the olanzapine drug section, we saw that 5-2 C receptor is responsible both for its antidepressant action as well as for weight gain. Okay, you can see go and see the mechanism there. I have explained how 5-HT2C receptor is responsible for weight gain as well as the antidepressant action. Okay, so from these two blockade, quetiapine will be acting as antidepressant and also will be providing anxiolytic effects. Okay, so summarizing the above two, D2 receptor and 5-HT2A receptor responsible for antipsychotic effect. D2 receptor and 5-HT2A receptor antagonism, not agonism, my friends. Okay, 5-HT2C receptor and 5-HT7 receptor antagonism will be responsible for antidepressant and anxiolytic effect. Anxiolytic effect. Now coming to the other receptor profile, which is also important, the histamine and the adrenergic receptors. Okay, best is divide the page into two. At one side we will be discussing about histamine, and the other side will be discussing about adrenergic receptors. Okay, so actually quetiapine is used as off-label for insomnia. Why? Because it has a strong affinity. It has a strong affinity for H1 receptors. It has a strong affinity for H1 receptor, and what does it go and do there? It blocks H1 receptors. So H1 receptor antagonism is mainly responsible for the sedation. At the same time, what we read earlier, that H1 antagonism is responsible for sedation as well as weight gain, as well as weight gain. So if someone asks you about the side effect of quetiapine, so we can get from this receptor, we can come to know that quetiapine is having two side effects, that is sedation and weight gain, and that is mainly because of H1 antagonism. Do remember this when we will be combining the side effect, then we will be again discussing about these points. Okay, coming on to the adrenergic receptors, quetiapine act as a potent alpha 1 receptor antagonist. Remember, my friend, it is potent alpha 1 receptor antagonist. So what does it will do? What does it do? Alpha 1 receptor agonist. Where are alpha 1 receptor presents? Mainly in the blood vessels. What alpha 1 receptor causes? Vasoconstriction. Since quetiapine will be coming and it will be antagonizing the alpha 1 receptor, which will be causing vasodilation, pooling of blood, and thus it will be decreasing the BP. So because of the alpha 1 receptor antagonism, it will be responsible for orthostatic hypotension. When do we need to be careful about this side effect? Mainly during the initial titration period. We should be careful about the orthostatic hypotension side effect of quetiapine mainly during the initial titration period. Why? Because the body is not accustomed to the drug, so it can lead to fall because of the hypotension. At the same time, do remember it blocks alpha 1 receptor, and at the same time it also blocks alpha 2 receptor. What we read, that alpha 2 receptor. Now alpha 2 receptor is also blocking alpha 2 receptor is responsible for antidepressant action. Okay, my dear friends, understood? Okay. So these are the properties of acting on histaminic receptors and adrenergic receptor which are responsible for weight gain, somnolence, as well as hypotension. So if someone asks you which receptors are responsible for quetiapine causing weight gain or sedation or hypotension, then we'll be mentioning about the histamine and adrenergic receptor, mainly the H1 receptor and the alpha 1 receptor. Coming to the now, the another group of receptor, that is muscarinic receptors. So do remember that quetiapine has a mild muscarinic receptor also. It has low affinity. What it has? It has low affinity for M1 receptors. Low affinity for M1 receptor. So since it has low affinity for M1 receptor, so we can see since it is an antagonist on M1 receptor, so we can see anticholinergic side effects. What are the anticholinergic side effects we can see? One is dry mouth, okay, and the second one is constipation. Second one is constipation. Since these are mild, so these side effects are not very common because the affinity for the muscarinic receptor is less. Now till now we are discussing about the role of quetiapine. Now we also discussed that the metabolite of quetiapine, which is norquetiapine, has also a role in clinical action of quetiapine. Okay. So norquetiapine has a pharmacological profile, distinct pharmacological profile as compared to quetiapine. Okay. Here we need to understand its pharmacological profile. Why? Because by understanding the pharmacological profile of norquetiapine, we'll be able to understand its antidepressant action. We will be able to understand its antidepressant action. Antidepressant action. Okay, my friends. So coming to norquetiapine. Norquetiapine works by mainly three methods. Works by mainly three methods. The first one is, remember, we all told that quetiapine act as a potent norepinephrine reuptake inhibitor. So that function is actually caused by norquetiapine. So what does norquetiapine do? It's a potent norepinephrine transporter inhibitor. Potent norepinephrine transporter inhibitor. So what it will do? Norepinephrine will not taken back into the synapse. So it will be increasing norepinephrine in the synaptic cleft and will be responsible for antidepressant action. Second point to note, it's a partial agonist. What it is? Partial agonist. Where it is partial agonist? 5-HT1A receptor. Can you tell me the other name of other drugs which are 5-HT1A receptor partial agonist? Do you remember any? Yeah, one is buspirone. One is buspirone is there. So for what buspirone is used? It's used as an anxiolytic. So here also, because of this action, quetiapine will be working as a anti-anxiety effect. This receptor profile will be responsible for anti-anxiety effect, and also it will be responsible for antidepressant effect. Understood, my friends? Coming to the third point. What is the third point? 5-HT2C receptor antagonism. 5-HT2C receptor antagonism. So in the previous lecture of olanzapine, we saw that 5-HT2C receptors mainly are present on the dopamine interneurons. Okay. So through the dopamine interneurons will be inhibiting the dopamine and the norepinephrine in the prefrontal cortex. So if we inhibit the 5-HT2C receptors, the dopamine interneurons will be get inhibited. And since the dopamine interneurons will get inhibited, they will not be able to inhibit the dopamine and norepinephrine neurons in the prefrontal cortex. Hence, by inhibiting the 5-HT2C receptors, what we will be doing in turn? We will be increasing the dopamine and norepinephrine in the prefrontal cortex, and this will improve the cognition as well as have antidepressant effect. So let me explain you again what we read earlier. Now what is 5-HT2C receptors? 5-HT2C receptors are actually present on the dopamine interneurons. So dopamine interneurons in the prefrontal cortex in then project to the dopamine and the dopamine and the norepinephrine neurons in the prefrontal cortex. Okay, so what will happen? Sorry, correct my. Let me correct my friends. 5-HT2C receptors are present on the GABA interneurons in the prefrontal cortex, and that GABA interneuron will be in turn projecting onto the dopamine and the norepinephrine neurons in the prefrontal cortex. So when we'll be inhibiting the 5-HT2C receptors, what it will do? It will in turn inhibit the GABA interneurons, which will be in turn not allow GABA to be released onto the dopamine and the norepinephrine neurons. So the norepinephrine and the dopamine neurons will not get inhibited, and hence it will lead to increased release of dopamine and norepinephrine in the prefrontal cortex, which will be leading to its antidepressant effect. So, in summary, if we summarize this and if we see the antidepressant effect, the antidepressant effect of norquetiapine is due to first norepinephrine transport inhibition, which will be increasing the norepinephrine in the brain. The second is 5-HT1A receptor partial agonist, which will be acting as an antidepressant and anxiolytic action. And the third is 5-HT2C receptor antagonist, which will be in turn increasing the dopamine and the norepinephrine level in the prefrontal cortex, and which will lead to have antidepressant effects. Okay, so these are the three main mechanisms by which norquetiapine works. Okay, and because of this reason, because of all the above three mechanism, quetiapine, because of the above three mechanism, quetiapine is used in bipolar depression. My dear friends, it's FDA approved for bipolar depression because of this effect of norquetiapine. Second, it's also used as an adjunctive therapy in MDD, that is major depressive disorder. Okay, understood, my friends? So till now, it's I hope it. So coming to the next section of quetiapine, that is mainly the dose effect relationship. The dose effect relationship means that the clinical effect of quetiapine is mainly dose dependent, and there is a famous three beer hypothesis of quetiapine. What is the three beer hypothesis? The three beer hypothesis are the baby beer, doses, the mama beer doses, and third one is papa beer doses. So we can remember this. It's very easy to remember the three things. So what does baby always do? What is the work of baby most of the time? The baby prefers sleeping most of the time of the day. You see a 2-year, 3-year-old kid or 1-year-old kid, most of the time it prefers sleeping. So the baby beer dose is mainly used for sedation. What happens to our mother whenever the child becomes mischievous, or whenever the husband doesn't listen? The mother can't do much, so just they become sad. So mother becomes sad. So this dose, to improve the sadness of the mother, will be using mama beer doses. So this dose will be acting as antidepressant dose. And how mainly papas are aggressive, sometimes angry person. For baby do anything wrong, papa will start shouting, which will mainly, so we can resemble it to like agitation or psychosis. So this papa beer dose will be mainly using for antipsychotic dose or mania dosing for treating mania. So don't get don't get offended anyone. It's just for remembering purpose. So baby may sleeps most of the time. So baby beer dose will be used for sedation. Mother become easily sad. So for treating that, we'll be using mama bear doses. So it will be a mainly antidepressant dose. And Papa most of the time becomes very angry. So we'll be using antipsychotic in the for these doses are used for mainly antipsychotic purpose and antimanic. Okay. So coming to the in detail about the baby bear dose. Baby bear dose. So what is mainly the baby bear dose? Baby bear dose is mainly 50 milligram. What it is mainly 50 milligram. Understood, my friend? So at 50 milligram, which receptor will be getting activated? So it's all as per the which receptors are activating at which doses, and on that we'll be deciding the effects. So at around 50 milligram doses, that is baby bear doses, mainly the H1 receptor are occupied, and the quetiapine antagonizes them. It acts as an antagonist at the H1 receptor, mainly leading to sedation. Okay. So at this dose, it will be acting as a sedative or a hypnotic. Sedative or hypnotic. However, it will not have any. It will not have any antipsychotic or antidepressant action. Will not have any antipsychotic or antidepressant action. Okay. So you must be seeing in the word that many times we give as an off-label to tap in for sleeping purpose. Coming to the mama bear dose. Coming to the mama bear dose, which is around 300 mg to 400 mg. Okay. What happens at 300 and 400 mg dose? Mama bear. So moderate dose. Moderate dose means 300 mg to 400 mg. So what will happen? Norquetiapine will be formed. Norquetiapine will be formed from quetiapine. And what does norquetiapine do, my friends? We studied three mechanisms. The first mechanism, NET inhibition, increasing norepinephrine. Second, what we did, 5-HT1A receptor partial agonist. Partial agonist. And what is the third mechanism we read about norquetiapine? 5-HT2C receptor antagonist. So what it will do? All these three. What it will do, my dear friends? It will be acting as antidepressant. Okay. And this will be increasing actually dopamine and norepinephrine, mainly in the which part of the brain? Prefrontal cortex. Okay. At this dose, it does not fully block the D2 receptors. So mainly this dose is used for the antidepressant activity. Antidepressant activity. So if someone asks you at what dose quetiapine is useful for bipolar depression, so we can say it is useful at dose at around 300 mg to 400 mg. Understood, my friend? And beyond 600 mg, if we increase for bipolar depression, it won't add any meaning and would just increase the side effects. Okay, understood, my friends? Beyond 600, it will not be useful for bipolar depression. It will be just increasing the side effects of quetiapine. Coming to the papa bear dose. Papa bear dose. What does the papa bear dose is? That is high dose of quetiapine. That is 600 mg to 800 mg. Okay. So at this dose, what happens? What happens at 800 mg dose? This is important, my friends. At 800 mg dose, the quetiapine occupies approximately 60% of the D2 receptors. How much it occupies, my friends? 60% of the D2 receptors. And because of this, it has full antipsychotic activity. It has full antipsychotic activity, my friends. Full antipsychotic activity. Okay. So to summarize it, baby beer dose, mama beer dose, papa beer dose. 50 mg, 300 mg, and 800 mg. For if we see for the range purpose, 50 to 100, 300 to 600, and 600 to 800. You can say like this are rough levels. So baby beer dose is mainly used for sedation owing to its action on being a H1 receptor antagonist. Mama beer 300 mg to 600 mg dose, where norquetiapine acts mainly through three processes. First, the 5-HT2C receptor antagonist, NAT inhibition, and 5-HT1A receptor partial agonist, through which it will be giving its antidepressant action. And the third is at 800 mg dose, where it will be occupying around 60% of the D2 receptor and will be responsible for its antipsychotic activity. Although it's occupying 60%, but what we remember that in next 12 hours it will be getting dissociated very fast to around 0 to 20%, and this will be responsible for less hyperprolactinemia and less weakness. Okay, my friends. So this we have covered the mechanism of actions in detail. Now coming to in detail about the pharmacokinetics. Coming in detail about pharmacokinetics. So what all we will be discussing in pharmacokinetics? The first point which we will be discussing in pharmacokinetics will be absorption and bioavailability. In absorption, quetiapine is rapidly absorbed. In absorption, quetiapine is rapidly absorbed. Okay. Second thing is time to maximum plasma concentration, that is Tmax. After oral administration, the time to maximum plasma concentration is around 1.5 hours. See, all this whatever I am teaching are from the standard sources, mainly including comprehensive textbook of psychiatry, Stahl Essential Psychopharmacology, Stahl Prescriber Guide, and Carlet. Okay, so all these are reliable sources. You can quote it anywhere. And the steady state of quetiapine is mainly reached in around 48 hours. Steady state is mainly reached in about 48 hours. Coming to the So, an important note about the XR preparation that it should be taken without food with a light meal of less than 300 calories. Why? Fat increases the absorption of what? XR preparation. Okay. So fat increases the absorption, so it will increase the bioavailability. And there will be dose dumping. Dose dumping of quetiapine, which will be increasing the side effect. So the timing of food with respect to quetiapine is very important. Okay. Coming to the metabolism part, coming to the metabolism and elimination part of quetiapine. First, in this, we need to remember that what is the T half of quetiapine? T half of quetiapine is 6 to 7 hours. What is the T half? T half of quetiapine is 6 to 7 hours. Okay. Now coming to this, quetiapine is extensively metabolized by liver. It's extensively metabolized by liver, and by which enzyme mainly? CYP3A4 enzyme. It's metabolized by CYP3A4 enzyme, and it is metabolized into an active metabolite known as nor-quetiapine, which we have discussed earlier. Okay. So coming to the elimination metabolism we studied that it's mainly metabolized by liver. Coming to the elimination, so if we divide it into 73% of quetiapine is excreted as metabolite. 73% of quetiapine is excreted as metabolite, mainly in the urine, and the remaining 20% is excreted in feces. So elimination, 73% of the quetiapine metabolite is excreted in the urine and around 20% is excreted in feces. Coming to the protein binding, property of quetiapine. So quetiapine is highly protein bound. It's around 83% protein bound. It's around 83% protein bound. Okay. So here now we have completed with the pharmacokinetics and the pharmacodynamics. Now we'll be coming to the indications. Okay. Therapeutic indications. Coming to the therapeutic indications, my friend. So there are always two indications. One are the FDA approved. One are the FDA approved, and the second one are off label use. So coming to the first indication of FDA approved indication is schizophrenia. Schizophrenia. So it is approved for acute treatment of schizophrenia, for acute as well as maintenance. Maintenance treatment. Acute and maintenance treatment of schizophrenia. Okay. Second FDA approved indication is bipolar 1 disorder, mainly mania. Okay. Now in mania, it can be used in two forms. First, it can be used as monotherapy for acute phase, or it can be used as an adjunct along with lithium or valve. And it is approved for greater than 13 years of age. Sorry, in children, it is approved for greater than 10 year of age. Okay, approved for greater than 10 year of age in case of mania. The third one is bipolar depression. So for bipolar depression, it can also be used as a monotherapy. It can be used as monotherapy both in case of bipolar 1 depression, bipolar 1 as well as bipolar 2 depression. Okay, it can be used as a monotherapy. Remember this. And fourth, in case of major depressive disorder, it can be used as an adjunct therapy. In case of major depressive disorder, it can be used as an adjunct therapy. So there are mainly 4 FDA approved indication. First, as in schizophrenia as an acute treatment as well as for maintenance phase. Second is bipolar 1 mania, where it can be used as a monotherapy as well as an adjunct to lithium or valproate. The third is bipolar depression, both in bipolar 1 and bipolar 2 and as a monotherapy. And fourth, it can be used as an adjunct in case of major depressive disorder. Coming to the off-label use, the first off-label use is, this is important my dear friends to remember, that is Parkinson disease psychosis. So you must be wondering why it is used in Parkinson disease psychosis, specifically why it is said. You know why? Because of its low D2 affinity. Low D2 affinity. Since it is having low D2 affinity, So it will be blocking less dopamine receptor in the substantia nigra. So it will be blocking less in the substantia nigra. So what will be having? It will be causing less worsening of the motor symptoms in the Parkinson disease. So it will be causing less worsening of the motor symptoms in the Parkinson disease. So that's why in Parkinson disease psychosis, we use quetiapine as an off-label drug to treat psychosis because it causes less worsening of the Parkinson symptoms. Second off-label use is insomnia. So what we read about insomnia? What we read about the dose? Baby beer dose, that is 50 mg. Okay. So for insomnia, we can give from around 12.5 mg to around 100 mg dose depending upon the body weight as well as the age. In old age, obviously we will be using less doses, so we can start from 12.5 mg or 25 mg, while in adult we can start from 50 mg and then we can take it to up to 100 mg. However, here we need to see the risk benefit ratio, because although we'll be getting the benefit of insomnia by blocking of the H1 receptor, however there will be increased risk of what? Because of the H1 receptor antagonist, there will be an increased risk of weight gain and metabolic side effects. Metabolic side effects. Okay. Coming to the third off-label use, generalized anxiety disorder. It's not FDA approved, but generalized anxiety disorder owing to its property of 5-HT1A receptor partial agonist. Okay. The fourth is it can also be used in PTSD because it has seen that in some trials it has reduces the PTSD symptoms. Fifth is it can also be used as an off-label use for agitation in dementia. Agitation in dementia. When it is given in dementia, for what? Behavior problems. Behavioral problems in dementia can be treated with quetiapine. Okay. So, but here we have to remember one important thing, that FDA has approved a black box warning. Black box warning. What is more important here is this. We are giving in a patient of dementia, and at the same time FDA has approved a black box warning that it causes increased mortality. This is almost common for every second generation antipsychotic, that it increases the mortality in elderly patient with dementia related psychosis. With dementia related psychosis, it increases the mortality in elderly patient with dementia related psychosis. Okay, my friends. And the last thing, sixth off label uses, the sixth of label uses, it can also be used in BPD, that is borderline personality disorder. Okay, just to improve the mood, the impulsivity, and the aggression. Okay, so there are six off label use which you can see. First, Parkinson disease psychosis. The second one is insomnia. The third one is GAD. Fourth is PTSD. Fifth is agitation in dementia. But we need to remember the black box warning there, that it increases the mortality in elderly patient with dementia related psychosis. And the sixth one is borderline personality disorder, where it can helpful in controlling impulsivity, agitation, and as well as aggression. Okay, and as well as it improves the mood. Coming to the dosing strategies now, the most important section. Coming to the dosing strategy. Coming to the dosing strategy. So the dosing strategy actually varies by, first, what is the indication of the dosing? Okay, and the second, what is the formulation we are using? The immediate release or XR formulation. Okay, coming to dosing strategy. So coming to the first indication what was in FDA approved, how we'll be giving in schizophrenia. So for schizophrenia, the target dose is 400 mg to 800 mg per day. Okay. So mainly the target dose is 400 mg to 800 mg per day. Coming to mania. Okay. So for mania, the target dose will be around 400 mg to 800 mg same. Okay. So for both cases, the target dose will be 800 mg. Do remember, for both the cases, schizophrenia and mania, the target dose of quetiapine is 800 mg per day. It is given in Maudsley, so you can see from there. Okay. So in this case, the titration is often done quickly. So we can start with 50 mg HS and we can titrate it very quickly. And by day 6, we can reach up to the day 6 or day 8, we can reach to level of 800 mg per day. Coming to the bipolar depression part, bipolar depression, here the dose is mainly 300 mg to 400 mg per day. Increasing the dose beyond 600 mg is of no use. Do remember this. For bipolar depression, increasing the dose beyond 600 mg is not at all use. Why? Because it just increases the side effects. And mainly, if we see, quetiapine for bipolar depression is mainly given at night once. This is not a hard and fast rules. We can actually change it as per the side effects as well as the patient profile also. Coming to the MDD augmentation, what we studied in case of MDD augmentation. So for MDD augmentation, mainly we use the XR formulation. So what we told that we avoid in XR formulation, we avoid a high fatty meal because it suddenly increases the bioavailability. Okay. So here the target dose is in MDD augmentation, the target dose is mainly 150 mg to 300 mg per day. 300 mg, 150 mg, 300 mg per day. So summarizing all the doses. So for schizophrenia as well as mania, the target dose is 800 mg per day. Okay, my friends. The second one is bipolar depression. The target dose is 300 mg to 400 mg per day. And for MDD augmentation, where we use it as an adjunct, it is 150 mg to 300 mg per day. Okay. Coming for the off-label use, we already studied earlier the off-label use. I'm just revising it again so that you can cover it one place. Insomnia. What was the dose of insomnia I told? Mainly 2500 to 25 to 100 mg per day. 25 to 100 mg per day. The baby bear dose. Okay. Where it will be acting mainly on the H1 receptor. Now coming to the dosing in the special population. This is important. This is very important. Coming to the dosing in special population. First, we'll be seeing the geriatric population. First, we'll be seeing the geriatric population. So, what is the problem with the geriatric population? The geriatric population is that their renal clearance is actually decreased. So, if the renal clearance is actually decreased, so what will happen? Quetiapine level will be more in body. Quetiapine level will be more in the body. So, increased chance of sedation and hypotension. Increased chance of sedation and hypotension. Okay. So there will be increased risk of fall. So there will be increased risk of fall. So what will be the rule here to stay? Say start low. Start at low dose, typically at 12.5 mg, and go slow. Slower titration, slower titration, so that the body get time to get adapt to the side effects. And also the target dose will be less. Why? In geriatric population, there is super sensitivity to drugs. Why it is so? Because in geriatric population, what we see that there are neuronal loss. To cover for the neuronal loss, there are increased expressions of the receptors. Since there will be increased expression of the receptors, so the neurons will become super sensitive. So even at lower doses, there will be the affinity of the drug will very much increase, and the effect will be more even at lower doses. So the target dose becomes actually less in case of elderly population. Okay, and the titration will be very slow as compared to the adult population. Understood, my friends? So in case of old age, there will be decreased renal clearance. So we need to decrease the dose to starting with the low dose of around 12.5 mg with slow titration, and the target dose will also be less. Coming to the second special population in case of hepatic impairment. Why it is important? Because quetiapine is mainly metabolized by liver by CYP3A4 enzymes. Okay. So what will happen in hepatic impairment? We need to increase the dose. So we'll be mainly starting at 25 mg per day, or we will try to avoid it. Okay. And then even if we have to increase, we'll increase it very slowly at around 25 mg per day, depending upon the tolerance. Depending upon the tolerance. Coming to the child part, it's not approved for child except for bipolar in case of depression, where is approved for greater than 10 year of age. Okay. Now coming to the adverse effects of quetiapine. So already while studying the mechanism of action, we studied about the various adverse effects. Now we will be compiling all the adverse effects here so that you can study at one page. Okay. So the adverse effects, we told that they are mainly because of the receptor profile. So coming to the the common adverse effect. Coming to the common adverse effects. The common adverse effect are, first one is sedation. How? Because of which receptor? H1 receptor antagonism. Okay. So sedation can be one, this adverse side effect. It can be a dose limiting side effect. It can be a dose limiting side effect, especially in the early part of treatment. Okay. It can be a dose limiting side effect mainly in the early part of treatment. Once the patient develop tolerance, then we can increase the dose. Second will be metabolic side effect. Metabolic side effect. So quetiapine comes under the category of moderate to high risk antipsychotic causing weight gain. Moderate to high risk antipsychotic causing metabolic side effect. Okay, my friends. So what it can cause? First one, weight gain. Second is hyperlipidemia. Third one is diabetes mellitus and hyperglycemia. Hyperglycemia. Okay, so these are the metabolic side effects. So because of this metabolic side effect, we require the regular monitoring of the metabolic profile, which we'll be discussing in separate lectures in monitoring of the various side effects of the antipsychotics. Coming to the third side effect, which is orthostatic hypotension, which we studied. Orthostatic hypotension mainly due to alpha 1 receptor antagonist. Okay. Fourth is anticholinergic side effect. Anticholinergic side effect, what was it was dry mouth and dry mouth and constipation, my friends. Okay. These were the common side effect. Now coming to the less common but serious side effects. Coming to the less common but serious side effect. So the first thing is QTC prolongation. Okay, QTC prolongation. So whenever you are starting quetiapine, you should keep in mind that QTC prolongation can be a side effect. So before that, you should calculate the QTC interval. So what is the normal range for QTC? It's less than 0.44 for males and less than 0.47 for females. Okay, these are the normal range for QTC. Okay, so it is not generally associated with persistent or clinically significant QTC prolongation in most of the clinical picture. However, caution should be taken. When caution should be taken, if there is any underlying cardiac risk factor, if there is any underlying cardiac risk factor, or if there is any other medication that can cause QT prolongation or has propensity to cause QT prolongation. Okay. The second is, despite the low EPS risk, it can also cause NMS. However, the chance is very less. The third is tardive dyskinesia. See, these are the less common. These are the very less common. So it is very low as compared to the risk of tardive dyskinesia is very low as compared to first generation antipsychotic, that is okay. Even sometimes, you know what, quetiapine is used to treat TD. Quetiapine is used to treat TD because of its low EPS liability. Fourth, this you all must be knowing because this is one of the most important MCQ which comes in the NEET PG examinations. What it is that quetiapine can cause? What quetiapine can cause? Cataract. It can cause cataract. Okay. Also, it has been seen that very rarely quetiapine can cause thyroid dysfunction. Quetiapine can cause thyroid dysfunction. Okay. Very rarely quetiapine can cause thyroid dysfunction, and it causes dose dependent. It causes dose dependent decrease in free T4 level and total thyroid hormone level. However, TSH level remain normal. However, TSH level remain normal. Okay. Now coming to the next part, we have studied about the common adverse effect, less common adverse effect. Now coming to the black box warning. This is important, my dear friends. Black box warning. One black box warning we already studied, which is common for all second generation antipsychotic. That is first, that is increased mortality in dementia related psychosis. Okay, so there is an increased risk of mortality in whenever we are treating psychosis in patient of dementia. Okay, now the second is suicidality. Second black box warning is suicidality. There is an increased risk of suicidal thoughts, increased risk of suicidal thoughts and behavior. Suicidal thoughts and behavior in children, adolescent, and young adults, young adult when it is used as an antidepressant or a- as an adjunct in MDD. Okay, so mainly two FDA black box warning. First, it increases the mortality in patients of dementia related psychosis, and second is suicidality. It increases the risk of suicidal thoughts and behavior. Coming to the drug interaction part, coming to drug interaction part. So divided into two. So what we know that quetiapine is mainly metabolized by which enzyme? That is CYP3A4. Okay. So at one side we will be writing the inhibitors, which will be increasing the quetiapine level, and the other side will be writing the inducers, which will be decreasing the quetiapine levels. Okay. So coming to the inhibitor, the first inhibitor which we always everywhere we see is ketoconazole. Ketoconazole. Second is erythromycin, a commonly used antibiotic. And the third is, in case of AIDS, we use protease inhibitors. Okay, protease inhibitors. So this will be inhibiting the CYP3E4. So there will be significantly increasing the quetiapine level. Increase the quetiapine level. So what we have to do? We need to decrease the dose of quetiapine. Okay, understood, my friends? Okay. Coming to the inducers part, what are the inducers? One is phenytoin, a commonly used anti-epileptic. Second one is carbamazepine. Carbamazepine. Okay. So remember, these two anti-epileptic increases the clearance of quetiapine by up to 5 times. Okay, my friends, remember that phenytoin and carbamazepine increases the clearance of quetiapine by 5 times. Hence, that decreases the plasma level drastically. They decrease the plasma level drastically. So, what we need to do? We need to increase the dose of quetiapine. We need to increase the dose of quetiapine. Okay, to maintain the efficacy. Done. This was drug to drug interaction in terms of metabolic enzyme. Coming to the interaction in terms of CNS depressant interaction. CNS depressant interaction. This is important, my dear friends. So, if it is used along with alcohol, benzodiazepine, or other sedative, already being a sedative agent, it will further increase the sedation. So common sense, what we need to do? Take precaution. Precaution of what? What precaution to take? First, fall. Second, over sedation. Okay. Now coming to the special population. Earlier we also discussed about the special population, but now we'll be mainly talking in terms of children as well as in terms of pregnancy and lactation. Okay, my friends. So coming to pregnancy part. So quetiapine is a category C drug. Category C drug. Okay, and it has a relatively low rate of placental passage. Quetiapine is mainly a category C drug and it has a relatively low rate of placental passage. Coming to the special second population, that is breastfeeding. So in case of breastfeeding, we see that quetiapine can easily pass through the breast milk. Okay, so quetiapine is excreted in the breast milk. However, if we see the relative infant dose, for quetiapine is 0.09 to 0.01% only, which means that actually the amount of quetiapine which is excreted in the breast milk is very less. Therefore, quetiapine is actually compatible with breastfeeding. Quetiapine is compatible with breastfeeding. So what could be the reason for low excretion of quetiapine in the breast milk? The number one reason can be it is highly protein bound. As we read it that the quetiapine is 83% protein bound, because of which the relative infant dose of quetiapine in breast milk is 0.09 to 0.1% only. Therefore, it is compatible with breastfeeding. However, what thing which should we monitor in the infant while the mother is on quetiapine? Mainly, we have to monitor for sedation in the baby. This is an important thing which should be monitored in the baby whose mother is on quetiapine. Coming to the third important special population, that is children and adolescents. Children and adolescents. So quetiapine is approved for schizophrenia in children and adolescents from 13 to 17 years of age, and in case of bipolar mania, it is approved from 10 to 17 years of age. 10 to 17 years of age. But what is the major risk factor in case of adults and adolescents? The major risk factor which quetiapine carries is high risk of metabolic side effects, which is mainly dyslipidemia and weight gain. Weight gain and dyslipidemia. Okay, my friends. Coming to the fourth special population, Parkinson disease psychosis. Because of its low D2 receptor affinity, quetiapine is used for psychosis in Parkinson disease. Quetiapine can be used for psychosis in Parkinson disease as an off-label. Okay, why? Since it is having low D2 affinity, so it will be worsening. The worsening of the motor symptoms in the Parkinson disease will be less with the quetiapine. as there will be less blockade of the D2 receptor in the substantia nigra. Coming to the now comparison with other antipsychotics. Coming to comparison with other antipsychotics. So as per Maudsley, what it is given, Maudsley says that Maudsley says that its efficacy is comparable to other antipsychotics. Okay, its efficacy is comparable to other antipsychotic. However, at the same time, it is less efficacious. It is less efficacious than olanzapine and risperidone. Olanzapine and risperidone. So this is an important point to remember. Now coming to the tolerability. In terms of tolerability among the antipsychotics, if we see quetiapine is having less propensity of EPS, okay, because and this property is attributed to its fast dissociation from the D2 receptors, okay, and low affinity for the D2 receptors. In terms of the metabolic profile, if we see, quetiapine is having worse metabolic profile as compared to aripiprazole and ziprasidone. Okay, aripiprazole and ziprasidone. However, it has a better metabolic profile. When compared with olanzapine and clozapine. Okay, so in terms of, if we see metabolic profile, quetiapine has a worse metabolic profile as compared to aripiprazole and ziprasidone, while in case of if we compare to clozapine and olanzapine, it has a better metabolic profile. Coming to the tolerability in terms of sedation, because of its high affinity for H1 receptors, it has a higher sedation property, as compared to many other antipsychotic like aripiprazole and risperidone. So this is, here we are now completing with the quetiapine. So once we will do a quick revision of the quetiapine. So we will be mainly revising the quetiapine in terms of 4 pillars. Do remember like this: 4 pillars and 3 beers. Quetiapine can be remembered as 4 pillars and 3 beers. Now what are the 4 pillars? Very easy to remember. The 4 pillars are, the first pillar we have to remember is, what is the first pillar we have to remember? That is D2 blockade plus fast dissociation plus 5-HT2A receptor blockade. Okay, so this is the first pillar. The second pillar which we need to remember is actually norquetiapine. The third pillar which we need to remember is H1 and alpha 1 antagonism. And the fourth pillar is dose response model. Okay, so we can summarize the entire of the quetiapine in this 4 pillar and 3 beer. So D2 blockade, fast dissociation, and 5-HT2A blockade. What these three mechanisms will be responsible for what? This will be responsible for antipsychotic action. Okay, fast dissociation means that on around only once D2 receptor is occupied in next 12 to 24 hours, the occupancy will only be reduced to 0 to 20%. That will be amounting to less amount of EPS and less hyperprolactinemia. And the third one is the 5-HT2A blockade, which is also responsible for low EPS and decrease hyperprolactinemia. Okay, coming to the second pillar, the norquetiapine. So what were the mechanism how norquetiapine was acting? Norepinephrine transporter blockade first. Second was 5-HT2C receptor antagonism, and third was 5-HT1A receptor partial agonist. Okay, so these three mechanisms will be mainly responsible for its antidepressant and anxiolytic action. Okay, my friends, coming to the third pillar, that is H1 and alpha 1 receptor antagonism. This will be responsible for first, H1 will be responsible for sedation as well as weight gain. This is a adverse effect. And the second one is by alpha 1 orthostatic hypotension. Okay, now coming to the fourth pillar in case of quetiapine, that is dose response model. Now dose response model mainly refers to the 3-beer hypothesis. What we studied about 3-beer hypothesis? The 3-beer hypothesis, my friends, let's revise very fast. 3-beer hypothesis is baby bear, mama bear, and papa bear. Baby bear means less dose of quetiapine, 50 to 100 mg, used for sedation. Why? At low dose it will be only blocking H1 receptor. Mama dose means 300 mg to 400 mg. At this dose, norquetiapine will be having antidepressant action. So at this dose, quetiapine will be having antidepressant action through norquetiapine. Okay, how? By blocking the 5-HT2C receptor, 5-HT1A, and NET blockade. Coming to the papa bear dose, papa bear dose is 800 mg. Here it will be acting as an antipsychotic as well as anti-manic. Okay, at the dose of baby bear and mama bear dose means till 400 mg it will be having very less antipsychotic action, while at a dose of 800 mg it will be having antipsychotic and anti-manic action. Okay, so at the end of the conclusion, we can say that quetiapine is a wonderful drug which can be used for the sedation purpose as well as an antidepressant in case of bipolar depression or as an adjunct to a MDD. Along with that, it can also use as an antidepressant, antipsychotic as well as antimanic. Thank you. If you like the content, do share, subscribe, and press the like button. If you find any correction during the video, please do write in the comment so that we can correct in the next further videos. Thank you so much.